Tom Petty and the Heartbreakers, Jefferson, Jericho Blues, 11:03 the time, an absolutely gorgeous day along the Southern California coastline. Welcome to the Mornings with Ed show on the all-new Voice of Laguna, broadcasting live and direct across the globe from this absolutely spectacular beachfront community of Laguna Beach, California. I'm excited about this conversation. You know how in the weeds I like to get on every subject, and we welcome in today Dr. Karishma Patel. Dr. Patel is a double board certified child, adolescent, and adult psychiatrist, and she's the founder of Lotus Care Psychiatry in Newport Beach, where you'll find shortly after starting this conversation, she provides thoughtful, evidence-based care for children, teens, and adults. And I am delighted to have this conversation. I'm going to shut down the phones right now so that we don't have any interruptions, and we welcome in for the conversation Dr. Patel. Good morning.
Good morning, Ed. Thanks for having me.
Thank you for being here. How are you today?
I'm doing well. How about you?
I'm having the best day. Been looking forward to this conversation for a while, and I'm fascinated by all things regarding human behavior.
Sure.
And I hope that I don't dumb up the conversation, but you specialize in ADHD and anxiety or disorders, OCD as well.
Yes.
And you also do parent coaching and crisis stabilization. I want to start, if I could, with ADHD.
Sure.
If that's okay.
Yeah, of course.
And particularly with kids. There's an inattention and a hyperactivity with kids. At what point do we make the diagnosis of ADHD and find that it's gone beyond a child just being a kid?
That's an excellent question. So I think the biggest misunderstanding of ADHD is, they have to have a lack of attention. A lot of times I'll get parents bringing their son in, for example, not being able to focus in school, talking out loud in class, kind of falling off their chair, not doing their homework on time. But then they come to me and they say, well, he can pay attention perfectly fine when he's playing video games. So the biggest misunderstanding of ADHD is actually not a lack of attention. It's really a disruption in the regulation of attention, if that makes sense.
It does. It does, actually, yes. So explain for our audience what that is.
Sure. So let's talk about the prefrontal cortex.
Okay.
I kind of like to think of the prefrontal cortex as like the CEO of your brain.
Okay.
It makes the important decisions. It's involved in attention, memory. So in kids with ADHD, the CEO is still there.
Right.
It's just not regulated as normally as other brains, meaning it has a hard time regulating when things are really important,
Right.
or when you're in a really stressful environment.
Right. Do adults manifest it differently?
Absolutely.
Okay. And for adults, I would guess that being late all the time or not being able to hold a relationship or a job, would ADHD contribute to that?
Absolutely. So ADHD really overwhelms the brain, which is why sometimes people get anxiety and ADHD confused. But ADHD in little kids can look like hyperactivity, but in adults it really looks like inattention and procrastination.
Right. And in treating it, in treating a child, I'm guessing there's a different process to treating a child than an adult. In an adult, I would imagine that it's more difficult, and the adult is, well, it's just the way I am.
So actually, the treatment is the same.
Okay.
The gold standard for treating ADHD is medication management.
Okay.
Stimulants are first line. There are also non-stimulant options. A lot of times, people with ADHD go to therapy. But to be clear, it's not to treat the ADHD, it's to treat the comorbidities or the other things that come with ADHD, like anxiety and depression.
Okay. And making the assessment on someone who needs medication, does that happen almost immediately, or does there have to be a lot of sessions and conversation with them?
Well, you can certainly take your child to get formal neuropsych testing. I'm able to do an ADHD evaluation. Usually it takes me about 1 to 4 hours to do a proper ADHD evaluation. I also like to talk to teachers because oftentimes kids present really differently at school versus at home. So if there's a mismatch, then there's like something else to look at versus if they sort of have the same symptoms in both environments.
Okay. And I want to stay on kids for a second if I could. Obviously, the earlier that you detect mental illness, the better chance of treating it. I'm just guessing here, but the earlier, the better chance of treating it. How early do children exhibit narcissism? And if you have a narcissistic child and it's untreated, is there a point that it's a lost cause and untreatable?
This is a really fun topic that you brought up. So yes, early intervention is key. I love to emphasize early intervention for really anything with mental illness. You bring up narcissism, and I kind of laugh just because I don't think I've ever really diagnosed a child with that. Typically, we see kids with oppositional defiant disorder, like ODD, or maybe conduct disorder. And if those symptoms persist, we can think about other things.
Okay, and I bring that up because the adults who I think, well, this is very narcissistic behavior in an adult, that behavior is very childlike. And I would think that they never grew out of whatever it was that they had as a kid.
Sure.
Am I is that a dumb connection to make?
Yeah, no, that makes sense. I guess if you don't mind me asking you, what's your understanding of narcissism?
I think, quite frankly, I think the President of the United States, when I think of a narcissist, I think of an adult that behaves that way. And then I think that if you paid attention to that same person in the 80s and the 70s, when they were younger, they were in their 30s, they still had that same behavior. And I don't know what he was like as a child, but I'm guessing that it was very similar.
Sure. So I guess going back to that, we don't diagnose narcissism, and I love being a child psychiatrist because we get to sort of target the maladaptive patterns before they really set in, which kind of brings up like a lot of parent coaching that I do, which really emphasizes a lot of like consistent care, love, and support, which would hopefully target all of those like behaviors and personalities before they really set in.
Right. Okay. All right, thank you, and thank you for rolling with me down that path. I appreciate that. You also specialize in OCD.
Yes.
And that includes ERP. What is ERP?
ERP is exposure and response prevention.
Okay.
That sounds really like big and scary, probably, but it's not.
Explain that to me, if you would.
Sure. Well, I can start with OCD. So OCD, it's kind of under the umbrella of anxiety disorders. And really, anxiety is when your alarm system is always on.
Okay.
And your alarm system is louder than your thinking center. So the alarm center is always worried, and then and it overpowers your thinking center. So OCD is kind of similar, but it can feel more intense. You have these intrusive thoughts. And the way I like to describe it to the little kiddos, because OCD is really, really common in kids and adolescents, is the intrusive thought, it's like a hiccup. It kind of just like pops up. And it's really hard to make it go away. And the more you try to focus on it, like hold your breath or like pour water on your feet or whatever, it actually makes the hiccup or intrusive thought worse. And so exposure response prevention is first line treatment. It is the gold standard. It is one of the most evidence-based things in mental health that works.
Okay.
Now, the thing is, it doesn't take away the thought because, I mean, we can't really get rid of a hiccup, right?
Right.
But we can sort of recognize like, hey, that hiccup doesn't belong to me. That hiccup is not me. And it helps us understand our alarm system doesn't always have to be on when we get that hiccup. Let's like focus more on the thinking center of our brain to calm it down.
That's wonderfully stated. Thank you for the clarity on that.
Yeah.
I really appreciate that.
Of course.
And I mentioned right before we went on air when I was describing the build out of this studio, I'm a little germophobic, and
Yes.
I've always found myself that way, even as a small child in school. I was not touching other pencils. Did that get to am I now full-blown OCD? Would you consider that?
That's also another big misunderstanding about OCD. When people say, oh, I'm super OCD about this.
Right.
I'm super OCD about that. I'm
Right.
like, well, that's not really OCD.
Okay.
OCD is more having an intrusive thought and then doing this compulsion to make the thought better. And then the way it works is we have the thought, we do the compulsion. We're teaching our brains that fear is real, and we need to do that compulsion every time. And really, it just heightens anxiety more and more.
Okay, thank you for that.
Yeah.
So a child who is OCD, who is clinically OCD,
Yeah.
is that learned behavior? Is that just something that, what we're describing here, is that learned behavior?
Most things with mental health is multifactorial. There's a biologic component, there's a genetic, and there's an environmental component. Truly, I believe that OCD is really not your fault. It's not something you can't control. It's like a hiccup. It just kind of happens.
Right.
And it's really hard to make sense of it.
Okay, thank you. I want to get a little more, a little darker, if I may.
Sure.
Okay. I'm curious as to how young you can detect antisocial behavior. Normally, if you hear, okay, if a child has killed a pet, that certainly you've discovered it then. Do you have to harm it? Do you have to wait that long, or can you detect antisocial behavior in toddlers?
So in toddlers would be pretty rare. I think if a toddler is harming an animal, I would wonder where they learned it from. They must have seen it somewhere, maybe from a parent, a family member, on TV, a video. So I wouldn't diagnose a toddler with antisocial personality disorder.
Okay.
I had mentioned, so with ADHD comes oppositional defiant disorder, and in teens that can present as conduct disorder, stealing, violating the rights of others, not listening to authority figures, very truant behavior. Those are kind of all the signs that, hey, if we don't target this now and do all of these early interventions, this could turn into antisocial personality disorder.
Okay, thank you. And I want to stay with kids for just a second, if I can here. A child who's only comfortable at home, and maybe they get queasy or separation anxiety as early as kindergarten when they go for their first day of school. We've all been a little nervous that first day of school, but let's say it continues into first, second, third grade. Might that be something as simple as maybe he lives in a transient family, that they move a lot, and what would the treatment be for that, and how do you treat that child?
So what you're describing really is under the umbrella of anxiety, and a kid with separation anxiety disorder. It's also really similar just to a kid that is scared to sleep alone in their room in the dark by themselves. So a lot of parents, they want to sort of make their child feel better in the moment.
Right.
So they give in to the avoidance. So you have this anxiety and then you have the avoidance. But what does that teach the fear? It teaches your brain that the fear is real. So we need to keep doing that avoidance behavior because that keeps you safe. So really, it goes back to, it's all kind of intertwined, but exposure, baby steps.
Okay. And you also do parent coaching.
Yeah.
Which I've often said here is necessary. That may be one of the most necessary things to teach people to parent or coach parents.
Sure.
If in fact you have a client and that it's a child, and that child has told you of obviously they've opened up to you, they've told you all of everything that's happening in their lives. When you feel the need to bring the parent in for coaching, is it difficult to find separation in keeping the child's secrets close and coaching the parents?
Yeah, that's a really great question. So how do I protect their privacy?
Right.
But then also guide the parents.
Correct.
Really, it's a conversation I try to have with the parents and the child. If I feel like if the child is telling me something that I feel could be really beneficial to parenting and the home life, I'll just tell the child. Say, hey, how about we tell them together? Do you want to tell them? I can tell them. How do we do this?
Okay.
Just open dialogue.
Okay. And are there times where parents will come to you for coaching without you having seen the child?
Typically, it involves seeing the child.
Okay.
Yeah.
All right. And I'll stick on this. I'll stick on this vein if I can. I'm loving this
Sure.
conversation.
So am I.
In parent coaching, how often are children's maladies the product of parents with maybe untreated mental illness of their own? And if you find that, do you recommend that they come and visit you privately?
Well, I really don't ever want to put blame on the parents, because being a parent is just so tough, especially like in this day and age.
Right.
Something I really focus in like with the parents are, hey, if you want your kid to act a certain way, you have to act that way.
Right.
You have to model that behavior. And then a lot of times they're like, oh, okay.
And it's just as simple as that. And then they get it.
Sure.
Okay. You also have a particular passion for supporting individuals that are navigating either autoimmune or other chronic illnesses. In my mind's eye, I'm trying to put together what kind of chronic illnesses and what kind of support would be required that you would lend.
Yeah, when I mentioned chronic illnesses, so I mean like autoimmune diseases like ulcerative colitis, Crohn's disease, lupus, things like that. Gosh, being a kid and a teenager is so tough, and then throwing an autoimmune disease on top of that, it's even more difficult. Also, like having to take medications, having to deal with side effects is so difficult and frustrating to navigate. And then oftentimes, like, kids feel really anxious when there's something going on. For example, like a kid with Crohn's disease, I know a kid with Crohn's disease that is really stressed, like going out to dinner, because he doesn't know like what's going to be on the menu, where the closest bathrooms are, and that brings up a lot of anxiety and depression.
Right. And I want to stay with that because in that vein, bullying might be a problem for that child.
Absolutely.
And I'm curious as to when you combine bullying, just as it was 40 or 50 years ago without social media, now you add social media into the mix. Is that the most pervasive problem facing teenagers, social media and bullying? And are we fighting a losing battle?
So here's the thing. Smartphones are not inherently bad. However, they should be used with moderation. And when you bring up social media is just like constant overstimulation to the nervous system and to the brain. Your nervous system and brain, it's meant to rest. It's meant to be on sometimes and then off at other times. So, but with social media, it's constantly on. The way I like to describe it is just like, imagine someone constantly just tapping on your shoulder all day long. It's not super painful, but you can feel it.
Right.
And then at the end of the day, I mean, I would be highly irritable, and then I would have difficulty sleeping. And that's social media. And kids are always up for constant like evaluation, like, oh, how many likes did I get? How many views did I get? There's this constant overstimulation and evaluation. And this is really important for the vulnerable population, and I call the vulnerable population teenagers, because their brains are not fully developed. I mentioned earlier with ADHD, the prefrontal cortex is like the CEO of the brain. Well, your prefrontal cortex is not fully developed when you're a teenager, but we're giving them smartphones and we're giving them social media, and we're sort of expecting their brains to act like adults, like they have a fully developed prefrontal cortex. So kids that are really anxious will then go on social media to seek validation, and then they'll scroll. Their anxiety will kind of get better because they're distracted. but then it kind of feeds into this loop because then they're distracted, but then they're constantly like comparing themselves, and then it brings up more anxiety.
Right. It's a constant need for
Yes.
positive reinforcement that
Yes.
they only get from this device that really it doesn't mean anything. And they're getting reinforcement from something that doesn't mean anything.
Yeah.
Yeah. Wow. Okay. Thank you for that.
Yeah, of course.
Before I go dark, because I'm going to go dark again here
Okay.
in a moment. Your practice, Lotus Care Psychiatry,
Yes.
is in Newport Beach.
Yes, it is.
If a family sees the need to bring, whether it's a teenager or a child, or come in as a family, what are the first steps? What do you do with them first?
So initially, I would just have an initial consultation, either over the phone or in person, just so I could get to know them and they can get to know me and see if I'm a good fit for them to treat them. And if they feel like that's a good fit, initially, an evaluation is about 90 minutes. I like to describe my practice as very like boutique style, where I'm giving really thoughtful care and not feeling rushed in my patient care. So it really consists of me trying to get to know them to the best of my ability, trying to understand their home life, who they live with, what school's like, all that stuff.
And if it takes more than 49 minutes, then it's going to take more than 49 minutes, and
Yep.
you give them that time.
Yeah.
Right.
Ideally, it's 90 minutes.
Oh, look
Yeah.
at you. Already out of the gate, even better. That's, Lotus Care Psychiatry, by the way, is in Newport Beach. I'll remind our audience how to find you before we close up. So I have an adult daughter.
Okay.
And I found great fortune in her first kindergarten teacher and first and second, in those teachers, the first, second grade teachers, to be wonderful, very nurturing, very reinforcing positively. I found that to be just so beneficial to her later years and her success in school and success now as an adult, all of that. Should early educators, like the kindergarten first and second graders, have some training and background in psychology?
I don't know if that's necessarily a requirement. You know, when you're describing these teachers and the impact it has on your daughter, I think the first thought I had was connection,
Right.
not really background of psychology. The connection is so important in the youth.
Right. Okay. And what signs should a teacher or counselors look for as warning signs for kids? And how early in a child's education should those educators look for warning signs and notify parents maybe?
Sure, like warning signs that this kid may be anxious, depressed,
Correct.
etc.
Yeah.
So, you know, depression presents differently in children and adolescents than it does in adults. You know, in adults, you see probably like a lot of tears, a lot of crying. But in children and teenagers, you see like a lot of irritability. And in teen boys, you see withdrawal, isolation, just going into their room. And then sometimes I'll have parents say, oh, but, you know, they have a great time with their friends. They're laughing so much. Well, the thing about kids and teens is they're really good at masking their depression and their anxiety. So irritability, isolation, a decline in grades, things like that. And something I like to emphasize a lot is sleep. Sleep is like more powerful than anything.
It's regenerative.
For the youth.
It literally
Yes.
is regenerative. That's
Yes.
that's where our cells come back to life.
Absolutely.
All right, yeah, that's a good point. Thank you very much for that. Couple of darker questions, if I can, and I want to turn to schizophrenia,
Okay.
if I could. It normally, does a child show or exhibit signs of schizophrenia, or does it take a while for us to see those signs, and maybe not until later teen years, early 20s, or whatever?
So a teenager can develop schizophrenia. It's, you know, it's not common.
Right.
So if you have a teenager or a child that says, hey, I'm hearing voices, I'm kind of like seeing shadows, you really want to figure out, okay, let's take a step back. Whose voice is it? Is it mom's voice, dad's voice, anybody you recognize? How many voices are there? Is it inside your head? Is it outside your head? So if a kid is presenting with auditory hallucinations, you really want to think more of like a trauma instead of a schizophrenia picture.
Okay.
But it is possible for teenagers to develop psychotic symptoms. Technically, to answer your question, you need to have the psychotic symptoms for 6 months to diagnose schizophrenia.
Okay. And then there are medications available.
Yes.
And are they really effective?
They are.
Okay.
Yeah.
All right, great. I love knowing that. So, excuse me. A couple of years back, I interviewed a gentleman named Kevin Hines.
Okay.
Kevin Hines jumped off the San Francisco Bay Bridge in an attempt to take his own life. He survived that jump. Messed up his back, obviously broke his back in several places. But now he is helping others. And he had told me, which was, it brought a tear to my eye when he said, the moment my feet left the bridge, I knew I had made a mistake. Because I felt his pain because what he must have been going through to even to want to jump and then realizing what a mistake it was. How do you convince a person who might be suicidal of how big a mistake they're making before they take that leap?
Yeah. Well, I mean, it's a really, really big question. Going to this gentleman you had here, I'm so glad he's like doing better now, and now he's advocating for mental health.
He's a listener. Kevin Hines is out there somewhere. Yeah.
That's great.
Yeah.
I mean, how do we prevent someone from attempting suicide?
Does it come out of nowhere, and do they, or do they say they're going? Do you have the warning signs?
So, for the kids that are more impulsive and with ADHD, those suicide attempts are not premeditated, but for those that are really depressed, it is more like well thought out.
Okay.
It's really a lot of like therapy and coping skills. Like let's make a board. Let's make a list of all of the reasons you want to live, all of the people like you want to be there for and that are there for you. Okay.
And a child or a teenager, I'll say a teenager that cuts themselves. Is that a warning sign?
It can be.
Okay.
So most kids cut to relieve tension. I always ask, what does that do for you? It makes me feel better. So when they cut, they're not cutting to end their life. They're actually cutting to make themselves feel better.
Okay. And I think the most fascinating question, or the thing that I've thought about the most in leading up to this conversation, I could not personally imagine being a psychiatrist. It's a skill set that I don't believe that I have. So congratulations and thank you. My God, thank you. How do you keep yourself separate from your patients without getting drawn in emotionally and bringing it home with you? Or do you bring it home with you? I'm fascinated by that.
Being a child psychiatrist can definitely be heavy at times, but it's so rewarding, and I think it's so special to really be able to just sit with my patients in their most challenging and vulnerable moments, and getting to sort of help them understand what's going on in their brain is really gratifying. In terms of how do I wind down, I mean, I'll be honest. Sometimes I take it home with me,
okay. All right.
and sometimes I don't. For the more challenging cases, yeah, like I'll talk to my husband or I'll talk to a colleague, and maybe I'll just like think about it at night. But really, I have to take care of myself so I can take care of my patients. So I'm always talking to the kids about coping skills. So my coping skills that I do every single morning, I go to the gym, I run 3 miles, and then I go for a walk and I make my coffee. That's sort of my routine that grounds me and centers me.
Right. Routine essential for everyone, you think?
Structure.
Structure,
Yep.
Okay. All right. Lotus Care Psychiatry is in Newport Beach. Dr. Karishma Patel, at this point, I want to have this conversation again. Let's have it on a
Yes,
regular
I would
basis
love
if we
to.
can. How do our listeners find you?
So I have a website, www.lotuscarepsychiatry.com. I'm also on Instagram. My phone number is on my website.
Okay.
Yeah.
All right. And Lotus Care Psychiatry is in Newport Beach?
Yes, it's in Newport Beach.
All right. Well, congratulations.
Thank you.
And I cannot thank you enough for coming in this morning and,
Thank you
and
for
sharing
having
that.
me.
It was great. And again, let's do this again.
Absolutely.
All right. Dr. Karishma Patel, if you're looking for any more information, you can just buzz me here at the studio. I'm happy to give you that, share anything I can with you. 11:33 the time. It's the Mornings with Ed show, and it's the all-new Voice of Laguna. Thank you again, Doctor.
Thank you.